Hello and welcome to this presentation on medical models of care for critical care medicine in Ontario during a pandemic. My name is Brian Cuthbertson. I'm reporting to you today on the report of the Short Life Working Group on this topic, which I chaired. These are the group membership. They were reflective of practice across Ontario, particularly those who'd been exposed to pandemic challenges during the first phase. The executive summary of this project is such. The committee proposes a medical staffing model for both academic and community hospitals in Ontario, built on previous hubs that were put in place by the report done from the HHR committee. We've built clusters on top of this to describe the full care team. It's a highly flexible and scalable and can be modified to local needs. It's a tiered system based on medical competencies and our experience. It has educational materials and indeed curricula relevant to each tier of doctor, and it discusses augmentation strategies to support the medical team, including skills-based teams, telemedicine, and external support for physicians. It sustains ability is vital and wellness is considered. We are now in the second wave. It's the 30th of October as we record this. And we've been able to identify that the system within the Ontario has responded with great flexibility and shown reasonable surge capacity, but a recognition that more can be done. The non-medical human resource group, the HHR group, is ahead of us and has already produced, and you should have received their report. It is recognized that that report has implications for the medical staffing model, and therefore that was going to be central to how we considered this matter. The Short Life Working Group is brought together to make recommendations to the command table, and these are those recommendations. The timelines ran from August the 27th, 2020 through to the dissemination date, which is the 31st of October, and to which time the group had 3 meetings. The aim was to develop a model for medical staffing of critical care units across the province during a future pandemic or indeed future waves of this current pandemic. The objectives were to show flexibility, scalability, to be applicable across scientific health science centres and community centres, to have good communication structures, to look at impact on medical training as well as on other services, as flagging the knock-on effects that could occur as they did in the first wave. The working principles that we work by is that the constituents of the group should be reflective of practice. Patient safety should be a priority. Critical ill patients who are highly infectious diseases represent a far higher workload and dependency than their equivalent critically ill patient, and this needs to be taken into account. The group will work closely with the HHR group and will learn the lessons from the first wave. Educational support for MDs according to their tier will be supplied, and staff must be given clarity on these roles within their scope of practice. Partnerships between institutions and across the system will be considered, and the working group will not make specific recommendations on knock-on effects that may occur as a result of these, but we will flag them. The working group will not consider space, equipment, non-medical resources. Considerations for the medical model. Well, the key features would be a tiered model based on physician competencies and experience. These would be identified in advance. There would be learning goals, indeed curricula developed with educational materials, a tiered approach to this problem, and we would consider it in regard to doctor-to-patient ratios. It's recognized that patients suffering from pandemic infection has a higher medical and nursing dependency than the equivalent critical care patient. Further features are we've designed a pyramidal model, a cluster that sits on top of the existing hub. They can be generated, modified, and multiplied as necessary. They vary with level of dependency within critical care units and the level of demand and surge at any one time. There are ranges within these, and local flexibility will have to be applied there. And it does indeed mesh with the HHR plan. The proposed model for a health science centre identifies that health science centres have medical trainees. They often have key specialties on site, which means there's more doctors generally. The severity of illness is often higher, and there are more ventilated patients, for instance, in health science centres in generality. They supply key regional services which will be impacted by surge, and the hub and cluster model will likely work in these centres. Let me show you the model. This model here, as you can see, is based on the hub structure identified by the RRT group, and this is the hub structure there. It identifies the nursing to patient ratios, nursing to bed ratios within the hub, which has 2 core teams within it. More detail of that is available in the RRT report. We propose in principle to build tiers of doctors on top of this cluster to support and work within this cluster and with the hubs, running from tier 1 down to tier 4. We identify the triage level at the time for each model and the doctor to patient ratio, as well as the optimal ranges. So if we start with academic hospitals during normal practice or during minor surge, then we would not yet have the hub system. We've perhaps identified 10 beds here, level 3 beds, perhaps 15, with 1-to-1 nursing ratios in line with normal practice. The hub on top of that would be a tier 1 MD, which is a critical care physician, possibly 1 tier 2 MD, which in normal practice would be a critical care fellow, and 1 or 2 tier 3 or tier 4 MDs, tier 3 being an MD with some critical care experience as a resident, and tier 4 being an MD who does not have that. The medical MD ratios there are about 1 to 3, and the MRP ratios are in the range of 1 to 10 to 15. When we move on to moderate surge, often called contingency in the HHR report, 115 to 125% activity or an equivalent drop in the staffing, then we've been forced to split the hubs to get this model to work. And here are 3 core teams within 1.5 hubs, so physicians would have to cross a hub. The cluster on top has 1 critical care physician at tier 1, has 1 tier 2 MD, and at that time we start to suggest consideration of skills-based teams, more of which I'll discuss in a second. 1 tier 3 or 4 MD, and indeed 1 of the other tiers. That's a ratio of 1 to 4 MDs to patients and 1 to 15 for MRPs. When we move up a level, now we're at major surge, greater than 125% activity or equivalent drop in staffing. Then we identify 1 critical care physician, but now with 2 hubs and 4 core teams below as identified here, we would effectively split the hubs in 2 with 1 tier 1 physician for both hubs, but a tier 2, a tier 3, and a tier 4 physician for each hub there. By this stage, we would be recommending skills-based teams to augment the services and relieve critical care physicians from skills-based roles so they can focus on some of the other activities of a critical care physician. And our MD ratios and MRP ratios are probably pushed to about the top of the range at this extent. These clusters can be multiplied up, and they need a central medical and admin command within each hospital once you get up to a number of clusters. And we make recommendations on who might be the members of such a hub. For the community centres, we identify that the key considerations are different. They do not usually have trainee staff, and indeed in the first wave of the pandemic, their trainee staff were withdrawn. Key specialties are not always on site. Severity of illness is often lower, but may not be in a pandemic, and the doctor-to-patient ratios are usually higher. They transfer out patients earlier because of their limited ability to surge, and therefore MD staff augmentation strategies need to be given high priority in community centres. So again, let's look at normal practice here. Then very commonly in a community hospital, 1 tier 1 MD will look after up to 20 beds, certainly 10 to 20, mixed level 2 and level 3. The MRP ratios there are relatively high compared to health science centres. With moving up to moderate surge, 150 to 125, then we've identified this as 2 hubs. Now the hub structure is introduced. And again, one tier 1 MD would be at their limit with that level of activity. So we would be considering transfer to other facilities earlier for these facilities and skills-based teams augmentation at an earlier stage for community hospitals. For major surge, one tier 1 MD will not be able to deal with the higher severity of illness and the higher patient numbers. So we're recommending identification of a tier 2 MD. A tier 2 MD may, in this environment, be, for instance, a staff anesthesiologist who has many advanced skills and reasonable knowledge of the critical care environment, who can work with a tier 1 MD. But certainly assurance of transfers and skills-based teams augmentation will be vital. We're also considering whether external staff support in situations where patients can't be transferred, is there an opportunity to move staff physicians, for instance, critical care MRPs, from areas that are under less pressure to help in areas that are under more pressure, again, when transport cannot be arranged. Telemedicine support, particularly for physicians, staff physicians who are unable to attend the hospital due to, for instance, isolation, should also be considered. The clusters can be multiplied up here, but there's often less room to do that in a community centre. And indeed, the ability to have a central command will be limited by the lower capacity generally of staffing as well as beds within the community centre. Clinical competency assessment and educational support for tiered MDs is extremely important. Here are the formal identification of the tiers, as I've shown you previously. Tier 1 being a fully licensed critical care physician. Tier 2 could be a staff anesthesiologist who practices with acutely ill patients, or a senior anesthesiology resident who completed all their critical care rotations, or a critical care fellow / subspecialty resident. A tier 3 physician is an acute specialty resident, usually who has done at least 1 month of critical care in the reasonably recent past, or a staff physician with relevant critical care experience in their past. A tier 4 physician could be a physician from any background, staff or trainee, who does not have recent critical care experience. To identify the appropriate tier for the physician, then the physician is asked prospectively to go to this web link, which is part of the Quick ICU training educational website, which was developed at the early phase of the pandemic. And they will be able to follow a questionnaire through that will identify their tier. It's done by self-assessment. It basically produces a competency passport which identifies their tier. And the passport will inform the placement of that MD within a critical care at whichever hospital they work. The passport can be produced at the time of presentation at the hospital to help them get attached to the appropriate team. So a passport may look something like this, with the identification of the physician, their tier, as well as their education curricular requirements. The educational resources for MD have also been made available. Physicians of all grades who worked in critical care need educational support, and ideally this would be done formally through colleges and deaneries, and we would urge that deaneries consider this. But since we're now in phase 2 of the current pandemic, we have developed tools on the Quick ICU training site, and there are multiple sites around, including the Critical Care Learning and the Osler site. But the Quick ICU training site has now been adapted to do both the survey of the tier to identify the tier of the doctor, and then it will lead to a curriculum with educational materials that the doctor can go to through this hyperlink so that they can gain skills and knowledge before they come to work in critical care. So this is a screenshot of the web page. It will now have a section on the left-hand side saying Ontario Pandemic Plan, and you can see there's an explanation about the tiers for the doctor to look at. And then as they go down the page, you can see at the top, what is my tier is identified, a hyperlink to the questionnaire, And then once they identify their tier, the curriculum becomes available depending on the tier that they fit with. So here, for instance, is an example of a Tier 2 MD's curriculum in an ABC structure, and hyperlinks that will lead them to materials like this with a category, the topic, and the available formatted materials on the website, which is a range of narrated videos, short talks, one-page handouts, and a color coding system to identify the priority that they should give to these different bits of training. Now we'll consider augmenting, scaling, and flexibility in the model. Skills-based teams is a broader definition than intubation teams were perhaps during the first phase. They would have advanced technical skills. They would not work directly within a cluster, but clearly in clear support of a cluster. And they would be able to offload critical care physicians to allow them to focus on the direct delivery of care. Skills-based teams could cover in-hospital cardiac arrest, rapid response, central and arterial line placement, as well as an airway breathing, intubation and ventilation team. And they should be able to work in the majority of airway breathing circulation interventions without direct supervision from a Tier 1 doctor. They would often be physicians from acute specialties, particularly anesthesiology, perhaps emergency medicine, but also other acute specialties, particularly for things like code blue and rapid response type activities. They should be led by a staff physician, and as I say, skills-based team members can come from different specialty backgrounds. We recommend this is developed in all centres in order to supply support during at least moderate, if not always during high-level surge. Anesthesia and respiratory therapists. Well, respiratory therapists are already working in critical care. They may have to change their ratios within the hub structure. Anesthesia assistants, if their operating room is not currently operating, could also be significant help to support the team throughout their activities. External physician support has previously been identified, is something that has been worked on by the command table, and now the ability to get practicing rights and privileges within a hospital in the short term seems easier to achieve. We would only recommend this in a situation where the ability to transport patients is limited or not available, and it's easier to move physicians between hospitals than it is to move patients between hospitals. There's guidance from the CPSO highlighted at the bottom on this matter. Telemedicine, we think, has a role, enhance availability of Tier 1 MDs in particular, particularly if they were off-site, locked down, perhaps even burnt out, but certainly needing a break from practice directly in the hospital. They can work across institutions, and this would be more likely useful in the severe surge situation. There would be an investment in technology required to achieve this. We have to think about sustainability, and we've listed a number of factors that affect sustainability. The number of patients, whether you're front line, geographic distribution, severity of illness, COVID positivity, the degree of relief, shift work, the length of each shift, the number of consecutive shifts, the rest between shifts, as well as wellness support for physicians. This issue is very important in a small group of physicians who could end up working long, difficult hours for a sustained period of time. Continuity of care during a pandemic could be challenging, and we identify this because MDs will not necessarily have the continuity and will be more likely to do shift work. And that introduces some challenges in a very pushed system. We encourage physician leaders to consider ways to assure patients and their families have some degree of continuity of care. Leaders should also consider developing information handling systems that could help and avoid loss of information. We identify impact on other services. Pandemic inevitably have significant impact on non-emergency services. We've seen this from the first wave. And the physicians who will have their own roles in other specialties, if they're taken to critical care, clearly cannot perform both roles. So these services may not be cut back, at least initially, and that might impact the number of physicians who could work in critical care. And that needs to be looked at closely over time as a pandemic develops. when planning to start critical care during future waves of the pandemic, the impact on their service must be clearly considered by hospitals and specialty-based leaderships around the hospital and indeed across the province. There is a significant risk of impact on postgraduate trainees and their training. Many of the doctors will be training grades. They will be missing other key educational training experiences during such blocks, and only very short blocks would minimize or reduce this factor. So this is also combined with a significant risk of burnout, and this group is particularly in need of targeted wellness strategies, since they are the most vulnerable group we're dealing with here. Finally, we adopt the recommendations made by the HHR report on communications and escalation, command structure, monitoring, data collection, hospital and regional readiness plans, and wellness support, which should include MD. So in conclusion, this committee has developed a medical staffing model appropriate for all units across Ontario. It interdigitates with the HHR plan. It's flexible and scalable to meet needs, and advice on putting the system into place is available at the end of this talk. These actions and support requests were identified with the command table. That's the end of the formal part of this talk. I will now continue on to show more detail in the appendices of this presentation, but the main key points have already been discussed. Doctor to patient ratios were identified in the models. Many factors affect appropriate doctor to patient ratios, severity of illness, isolation, nursing issues, etc. We've tried our best to work around that, bearing in mind that critically ill patients in a pandemic may not correspond to the level of dependency that occurs in other areas, but we do recommend that we do not go above 4 doctors to 1 patient, if at all possible, and 1 critical care patient, MRP, to the maximum of 20 patients. Ratios in community hospitals will have to be modified. Our next appendix relates to the physician tiers as identified by the competencies and experiences as discussed previously. A tier 1 physician is a fully licensed critical care medicine staff physician with full critical care competencies and currently practice in a level 3 critical care unit. They may care for patients in 1 or 2 hubs, up to about 20 patients. And strategies to avoid overworking this group are going to be important since they're a relatively small group of physicians. We do not recommend a curriculum of learning for these physicians since they are working within their space specialty. Tier 2 physicians could be staff physicians from other acute specialties outside critical care with recent and relevant experience looking after acutely and critically ill patients. Critical care hospital fellows or subspecialty residents with many but not all the CCM competencies, or a senior anesthesiology resident who's completed all core critical care training. Tier 2 MDs will work within a single cluster or a skills-based team. They can usually care for up to 10 patients under the supervision of a Tier 1 doctor, and they will be able to undertake the majority of ABC-based interventions. Tier 2 doctors who are not CCM fellows or subspecialty residents will often come from anesthesiology, but not solely. Their learning curriculum is identified according to those skills. And strategies to avoid overwork in this group are also important since it's a particularly small group, particularly the CCM fellows. Staff physicians from other acute specialties are potentially a larger pool, but they have to be willing, skilled, and able to do this work. The availability of staff physicians will also be acted by the demand for their skills in their base specialty. Tier 3 physicians are acute specialty resident physicians or fellows with at least 1 month critical care medicine experience during their training. Staff physicians with relevant and reasonably recent intensive care experience. They'll work in a cluster, single cluster, usually not more than about 5 patients. They should be able to undertake some ABC procedures, but with supervision from a Tier 1 and or Tier 2 physician. Tier 3 MDs need close direct or indirect supervision from Tier 1 and Tier 2 physicians for all their activities. They will usually be year 2 to 5 residents of acute specialties, such as the internal medicine and medical specialties, surgical specialties, anesthesiology, and emergency medicine. Tier 2, 4 physicians are residents and fellows from non-critical care backgrounds, or staff physicians who do not look after acutely ill patients. They work within a single cluster. They usually care for up to 5 critical care patients. They will not possess ABC skills. They will need very close supervision, and there will usually be residents also from acute specialties. They may be staff specialists, staff physicians from other specialties also. Special considerations for this group are they are often indeed medical trainees with very specific educational objectives within their own specialty programs, and these need to be respected. Their well-being is a prime consideration. We encourage postgrad deaneries to consider the balance of the use of these doctors in future pandemic care, as maintaining their wellness and their educational priorities is a priority. We also recommend engaging the Royal College as well as the trainees in these discussions. For Tier 2 to 4 MDs, we have identified and developed educational support materials. We've got learning curricula for each of these and developed for Tier 2, 3, and 4 separately. They've been linked to appropriate educational materials in the Quick ICU training. And once a doctor identifies their tier, they should follow the link straight through to their educational materials, which can also be accessed at a later time. Assurance of completion of these learning and objectives is entrusted to them as individual doctors. Appendix 3 is the assessment of tier status for doctors. This is simple. Following this hyperlink and following the survey instructions at this hyperlink, the website will identify their tier and it will print them out a competency passport for their reference and for future production. Finally, Appendix 4 is to do with loss of information, and we present as an option the consideration of the problem sheet to handle the information so that a sheet like this can be available for all patients so that there is a lower chance of loss of information in very busy units with a rapid turnover of patients and staff. Thank you very much. That's the end of this talk. Thank you very much for listening.